we advise to keep a video laryngoscope also around in case something goes wrong and your LMA also doesn't fit and you need to convert to a complete endotracheal intubation. So now once you have prepared the patient, you have gained his support and rapport and you've made him comfortable, you've brought him to the theatre. Next what? Monitors. So you put obviously the standard ASA monitors like your ECG, SpO₂, non-invasive blood pressure, and ETCO₂ under the mask. Generally put a Hudson mask or nasal prongs. So these are your standard monitors. What are invasive lines? So now that will depend on the comorbidities of the patient. So if the patient is like a cardiac patient where you think with low EF and you may need to put, you can go ahead with invasive arterial blood pressure lines and your CVP. Also, if the veins are difficult and the tumor is likely to bleed and you need a good vein, you can go ahead with CVP. Whether to catheterize? Well, an awake patient, catheterization, no, it makes them very uncomfortable, and that's why it needs to use fluids very judiciously. You can't run fluids because then the patient will want to pee. The other option is for catheters, otherwise condom catheter, or you put a diaper. But as I said again, if there is likely to bleed and you may need to run fluids, or if you may need to give mannitol to the patient, you can catheterize the patient under sedation and intraurethral lignocaine. So again, it's based on how long the procedure is going to be and how invasive, how deep and how vascular. When we use the technique and it aids us to see where we stand when we awaken the patient for testing phase. So it's not a mandate, but if you have it, it is better. You can know where and how awake the patient is. And SSAP and ECoG, that is electrocorticography, are generally used during epilepsy surgery, and they help to find sometimes even during motor and sensory to form the phase reversal, and your central sulcus is identified with it. So sometimes you may need to do SSAP monitoring. Apart from this, any other monitors as per your institutional protocol can be used. So then we move to positioning. So this is the OT layout for awake craniotomy, where you have the surgeons at the head end. Your machine is generally at the foot end. The anesthesia are monitoring everything from this. The infusion pumps are on your machine side. And then you have the neuronavigation system, which will aid the surgeon to diagnose and delineate which trajectory will be best without harming any vital organs of the patient. The scrub nurse and a tolly is on one side, and there is generally a sterile drape here which will delineate the sterile area from the non-sterile area. So mostly it is done with supine with head turn. You can have even the patient in semilateral, lateral, or rarely in semi-sitting positions. So mainly to prevent claustrophobia, we use transparent drapes, which thereby make the patient feel a little connected, not under the drapes as some eternal doom. And if you can also easily see the facial structures of the patient, and if you need to handle or do anything with the airway, you are easily able to manipulate the airway. So after the monitors, the next step is your scalp block. So now scalp is innervated by two mainly nerves, the fifth nerve, the trigeminal nerve and its branches, and the posterior rami of the C2 and C3. So now the trigeminal nerve has ophthalmic, maxillary and mandibular division. The ophthalmic branch gives off the supraorbital and supratrochlear nerves, which innervate the forehead and the anterior part of the scalp. The maxillary division gives rise to the zygomaticotemporal, which will innervate your forehead and your temporal region. And the mandibular division of the fifth cranial nerve gives rise to the auriculotemporal nerve, and it innervates your temporal areas, the lower lip and auricle, and the scalp above the auricle. So this entire area is your auriculotemporal nerve. These are your anterior innervation. The posterior is by the cervical nerves, the greater occipital, and the lesser occipital. They innervate the posterior scalp and skin over the auricle and the scalp in the lateral aspect from the head posterior to the auricle. So the main nerves which we block are your supraorbital, supratrochlear, zygomaticotemporal, auriculotemporal. These are your anterior blocks. And posteriorly, you have the third occipital, greater occipital, and the lesser occipital. The drugs which can be used are bupivacaine in 2 to 3 milligram per kg body weight, lignocaine 5 to 7 milligram per kg body weight, ropivacaine again 2 to 3 milligram per kg body weight. We generally prefer a combination of a long acting and a short acting so that the duration is longer and action is faster. Sometimes people add additives like adrenaline 1 in 2 lakh 1 drop, or you can add 100 units of hyaluronidase, which helps in good spread of the local anesthetic drug. So we now move to individual nerve blocks. Now the supratrochlear and supraorbital nerves, they both are blocked by a single injection. Trace your supraorbital notch. You go 1 centimeter medial to it, hit the bone, enter perpendicularly, hit the bone, and then deposit 2 cc of drug in that area. Then from the same injection point, you move a little towards the edge of the supraorbital, again deposit 2 cc drug there, and both your nerves will be blocked by this one wheel of injection. After that, we have the zygomaticotemporal now. So now this is blocked by your lateral border of your eye, that is your lateral canthus. 1 centimeter lateral, hit the zygomatic bone and you deposit 2 cc of drug there, and then slowly direct your needle to the edge of the zygomatic arch and again deploy the drug in this entire tract. Generally 3 to 4 ml is sufficient. The common complication with this is sometimes your facial branches get blocked, but do not worry, that will not cause any problem, except if you're going to monitor the facial nerve, then yes, the monitoring will be lost. Otherwise, as the drug wears off, the facial nerve will come back and there will be no problem long term for the patient. What about the auriculotemporal nerve? Now this is blocked just in front of the tragus. You 1 centimeter in line, again hit the bone and deposit 3 cc of drug. Always palpate for the superficial temporal artery there so that you don't do an inadvertent injection into the artery. These were the anterior blocks. Remember, you need to block them on both the sides. Even though the tumor resection may be from one side, you have to block both the sides primarily because 1, the clamps are bilateral, and 2, there can be mixing of fibers, plus your craniotomy can extend beyond the midline. So block both the anterior sides of the face. Then we move to the posterior blocks, where it is from the C2, C3 rami. So your greater occipital nerve and the lesser occipital nerve and the third occipital. So the third occipital nerve is where your inions is. So palpate the inion and deposit 4 cc drug in the center. The greater occipital is 1 centimeter lateral to it, between a line drawn between the inion and the mastoid process, or midway roughly. So again you feel for the ridge, draw a line and give 2 cc drug at this, which will block your greater occipital nerve. The lesser occipital nerve, you feel for the mastoid process, and 1 centimeter lateral to it will be your lesser occipital nerve. Again you deposit 2 cc. Some centers join all these and infiltrate in between also to completely form a ring block behind, so that no fibers are lost, because none of these are standard or strictly positional nerves. So it is best to infiltrate the entire area and form a ring block behind. Generally 30 to 40 ml is enough, 20 on each side, which will give you a good block. Some people also keep some drug remaining, and at the time of Mayfield clamp, at their insertion site of the pins, again 1 cc is injected just to complete the block. Your goals mainly remain that patient has to be cooperative. So you can give him sedation, analgesia, anxiolytic. Make sure the patient is comfortable in the position of the surgery, pad the bony points, and prevent any untoward side effects and complications. Also aid in brain relaxation so that it aids the surgeon to resect the lesion properly and completely and maintain cerebral hemodynamics. You also need to avoid any drug interactions, especially when you have electrocorticography monitoring during epilepsy surgery. So once you've given the block, you've positioned the patient, make sure again and reassure the patient that don't worry, we are all here, and if you have anything, any problem, you can sort it out, make the patient comfortable in the position, because once it is there, he will not be able to move for at least 3 to 4 hours. Now the steps of surgery are in 3 parts. The first is your craniotomy, where you open the scalp, the dura, and the bone flap is raised. Then you reach the tumor resection. After you open the dura, reach to the tumor, where you need definitely the patient to be awake to help you guide the resection part. And finally, you have closure and go back to normal. So during the craniotomy and the closure, patient can be awake or asleep. If you have done a good block with and a comfortable cooperative rapport patient, you may not need to give anything more than just your sedation and NSAIDs and painkillers, analgesia.